Ram today. We'll be continuing with our thoracic sessions which were left over yesterday in about 5 minutes.
Today we'll start with the thoracic session. Now we have Dr. Sriram who will speak on management of thoracic trauma, ICD and surgical management of rib fracture.
Good morning, respected seniors and my dear colleagues. Now, I'm going to discuss about the chest trauma. Thoracic trauma includes 10 to 15% of all traumas and almost 20 to 25% of trauma-related deaths. And there is a requirement of only 10% of this thoracic trauma where surgery is required. And the major mechanism of injuries are RTA, fall from height, and assaults. RTA being the most common injury. And 10% of trauma patients having rib fractures, and among these, more than 19% patients are managed by conservatively. And the mortality is 8% in LLD, and when flail chest involves, it increases up to 13%. And according to the National Data Bank, there is a less than 1% flail chest getting fixed. So there is a need for surgical fixation in this area. Coming to the flail chest definition, radiologically, 3 or more consecutive ribs fractured at least 2 points, and that segment will discontinue from the chest wall, and it causes paradoxical movement with respiration. And usually, most of these traumas will be having underlying lung contusion too. And the most common investigation, the basic investigation chest X-ray, which is most of the times underdiagnosed. The gold standard investigation is CT chest with 3D rib reconstruction. It gives the information of site and number of rib fractures, and if there are any associated hemo or pneumothorax or any lung contusion or lung injuries, and the quantification of displacement and other injuries like diaphragm injury. Coming to the initial treatment of chest trauma, first we have to stabilize the patient, stabilize the vitals of the patient first, and give adequate ventilation. And ICD insertion if required in cases like pneumo and hemothorax for optimization of lung expansion. And pain management very crucial in chest trauma, and usually we use NSAIDs, opioids. In severe cases we use intercostal blocks, paravertebral block, epidural, and it is better to restrict fluid if the vitals are stable. So coming to normal chest cavity physiology, the transpulmonary pressure, which is the difference between the intrapulmonary and intrapleural pressure, maintains the normal chest physics, and it is essential for the distension of lungs. Negative intrapleural pressure helps in lung expansion. When this negative pleural pressure disturbs with air, blood or fluid, anything, then there will be a disturbance in the transpleural pressure, and it causes the collapse of the lung. Now, aims of the chest drainage system. The aims of chest drainage system are to drain fluid and air and prevent them from coming back to pleural cavity, and mainly restore negative intrapleural pressure, facilitating lung expansion. In the area of ICD insertion, this is very crucial because nowadays not even surgeons, physicians and ER residents, ER people who are non-surgical people are putting ICD at most of the centers, and many complications have arising. It is not only the site of ICD that is important, it is a technique too that is very much important, and they need at least a minimum surgical skills to put an ICD. The preferred site for ICD insertion is covered with anteriorly by lateral edge of pectoralis major, and posteriorly by LD muscle, inferiorly fifth intercostal space, and superiorly base of scapula. It is kept in the mid-axillary line at the level of nipple. And the ICD system, there are 1 bottle, 2 bottle and 3 bottle system. The most commonly used is the 1 bottle system. We all may have seen the 1 bottle system, and this is the most commonly used for normal pneumo or any post-op lung resections or anything. And the 2 bottle system, when there is a minimal suction required, we use 2 bottle system, and the extra bottle will prevent the trauma to the lung caused due to that negative suction. And when there is a requirement of more suction, when for thick fluid or something, then we use 3-bottle system where drainage and water seal in second bottle and suction control will be maintained in the third bottle. And there are two types of suction system. One is wet and one is dry suction system. And wet and dry, both chest tubes are used to drain air fluid from pleural fluid, but they achieve this through the different mechanisms. First, come to the wet suction. It uses the water column to create negative pressure, and the height of the water in suction controls the and determines the suction level. And the bubbling, the visual bubbling in the bottle system confirms that the suction is working. And the pros of this wet suction system, it can be visually monitored for fluid drainage, and it can be used for large fluid collections. And the negative cons of wet suction are these cannot prevent air leak, and the water in the system continuously evaporates, so we have to frequently check the water in the bottle system. Dry suction system, this uses a mechanical regulator to give negative pressure. So, and the suction is typically regulated by a rotatory dial. So, some indication, some systems have visual indicators like a ball. Here we can see -0 to -40 level suction. So we can keep this at a required negative suction level. Usually we keep at the -20. And the pros of this system are dry suction system are, it is a quieter, there is no bubbling involved in this, so it is a quieter and less risk of water evaporation, and there is a wide range of suction levels. And negatives, it may be less visible than the bottle system for fluid drainage and may require more maintenance of the mechanical components. The Atrium Oasis dry suction system is one of the examples for this. Differences between the wet and dry suction system. Mechanism, the water column, wet suction system uses water column. There is a mechanical regulator in the dry suction system to keep negative pressure in the intrapleural cavity. And the water level in the chamber controls the suction control. And here we can use there is a rotator rail will fix at a particular negative pressure in the dry suction system. And the bubbling for suction and fluid levels are visible very easily in the wet suction, where the indication for suction and there is a less fluid visual levels in the dry suction system. And wet suction is a bit louder and potential for evaporation of water. So continuously I have to monitor for the water column level. And dry suction is a bit quieter and less risk of evaporation of water. And for prevention of air leak, dry suction is more helpful than wet suction. Coming to the surgical stabilization of rib fractures. So this is the classification of rib fractures. There are type A, B, C, and type A involves all the types, transverse, oblique, and wedge, but it is not displaced. But in type B, there is a minimal displacement of these fracture segments. In C, there is a complex, there is a severely displacement of fracture segments. So more commonly, type B and type C rib fractures are the ones which we usually fix. Bemelman criteria, he is a trauma surgeon. He has worked on this surgical fixation for many years and has given a criteria to fix the ribs. The flail chest, ventilator dependent patients, and the severely displaced fractures of type B and type C. Type B and type C are clear-cut indications for the surgical fixation. Whereas isolated fractures, when there are few isolated fractures, when there is no flail chest, then he has taken the age criteria and number of rib fractures. The age criteria is 45 years. If the patient is above more than 45 years and he has at least more than 4 rib fractures, more than 4 or equal to 4 rib fractures, and the pain scale is more than 6, then they have to be fixed. If the patient is less than 45 years age, the rib 6 or more than 6 rib fracture has to be fixed. Here, the preoperative assessment. The preoperative assessment is very crucial for rib fracture. Before going to the surgery, we should know how many ribs are fractured, how many are flail chest, what is the exact site of the fracture location, and one more thing, the scapula, the relative position of fracture sites of rib, posterior fracture sites of rib relative to scapula. Those all are important because under the scapula, the placing of this rib fracture is very difficult. So we have to assess all this preoperatively and carefully, then go for surgery. The operative technique, usually it is under general anesthesia with a left DLT with a involved lung isolation, and we usually do VATS. Most of the, more than 90% of the cases of chest trauma will be involving hematoma, hemothorax, so some other associated injuries. And one more thing, most of the time the radiologists may also miss diaphragmatic injuries in these chest trauma cases. So it is better always to visualize before fixing the ribs. So it is better to do VATS, put a utility port and see inside. If there is any hematoma or hemothorax, you evacuate the blood, then see for all the organs, see for the diaphragm, see for any active bleeders, see for any aortic injury, see for any other injuries. So see for any esophageal injury, and then confirm, and then you go for fixing of ribs. And this VATS associated is also used to locate the fracture sites from inside. We usually do VATS, and we just see the fracture site from inside, and externally we mark at the fracture sites, so that it will be helpful for us to place an incision exactly over the fracture site, so that it will be very easy to fix the ribs. So we use titanium rib plate system. So for the better fixation of these plates, we at least put a proper length of plates over the rib system, at least 3 holes on either side of the rib fracture, that will give a good stability of this rib fixation. And post-operative management, most of the patients are extubated on table. They give good results. But when trauma involves any neurological condition, those patients are sometimes will be on ventilator. We have to manage them carefully. And pain management is very crucial in rib fixations. We usually give epidural analgesia for 48 to 72 hours at least. And we restrict intra-op and post-op IV fluids to decrease the effusion. And if there is any requirement of blood, if the HB is less than 8 because of multi-trauma, you should give blood products. And early mobilization and breathing exercise, incentive spirometry are very helpful post-operatively. Coming to my experience of surgical stabilization of rib fractures, we have totally did rib fractures in 49 patients, which involves male and female, 42 males and 7 females. Most of them are males. And the isolated and combined fractures, 18 isolated and combined fractures are 31. Mostly these trauma cases will be associated with some other long bone injury or abdominal injuries. So the age distribution, most of the chest trauma patients we experienced are in between 45 to 60 age group. So mode of injury. As I already explained before, the mode of injuries are RTA, fall from height and assaults. RTA being the most common. Even in our study, among 49 cases, 41 are RTA. And the distribution of rib fracture. The mean number of fractures are 11. 2 to 8 ribs are the most common fracture sites. 22 are fractured on right, 26 on left. We have experienced 2 bilateral rib fractures too in train accidents. And 2 patients had diaphragmatic injury, and this is very important. These 2 patients, this diaphragmatic injury, in preoperative CT, the radiologist has missed this finding, diaphragmatic injury. Because of we did VATS prior fixation, we are able to identify that diaphragmatic injury, and we are able to repair the diaphragmatic injury. So VATS is always have an extra edge in these patients. This is the diaphragmatic injury that we have repaired. And clavicle is the most common associated fracture. And abdominal trauma is associated in 15 patients, where grade 3 liver injury in grade 3 and 4 liver injury in 8 patients. And the traumatic brain injury is associated in 21 patients. This is the bilateral fixation. Usually the ribs shouldn't be fixed bilaterally, because they have a feeling that someone is like something is constricting. It's a very constricting feeling. They may initially they may not even take a good breath too, because they will have that constricting chest feeling. So that bilateral is not advised. But these are the few conditions where I have said 2 cases, train traffic accidents. They have severe flail chest on both the sides, and the patient is on ventilator dependent. So we had no option than doing bilateral fixation. But these patients have a bit of discomfort, but they have improved drastically. And the surgery data, usually the mean time from the impact to surgery is 3 days. It is better always do refixation within 72 hours. So it gives a more fruitful result. If we take at least 2 weeks is at the maximum level. If after 2 weeks there will be a bone formation, if we have to do the refracture, we have to do the refracture fixation. After 2 weeks, we have to break the already formed bone, and then we have to do a refraction. This is a bit traumatic, and it's not an easy, as I say. So it is always preferred we do as early as possible in the chest trauma patients. It's better to do refixation as early as possible. And the duration of surgery, mean duration of surgery is usually 2.5 hours. And this involves the number of rib fracture and the site and the flail, and if involved bilateral or not too. And the most commonly fixed group of ribs. And as you see, the chest involves first 2 ribs doesn't contribute any volume to the chest, and the 3 to mostly 8-9 ribs, they form the major cavity of the chest. So from the 3rd rib to the 8th rib, it is better to fix those ribs because it forms the major cavity of the chest wall. So even in our study, the most number of rib fractures fixed is the 4th one. Sorry, is the 5th one, and most commonly fixed ribs are 4 to 7. And surgical outcome, the pain analgesia. The pain control is very important in the initial days of this refixation because they will be having a very severe pain. So we don't compromise on giving any painkillers and additional analgesia support. So we usually give multimodal analgesia, IV and epidural. Epidural we continue for at least 3 days. And this is the median numerical pain score. The pain score of the patient immediately after post-operative is 8/10, and after 1 week it is 4/10, and after a month it is drastically improved. It is 2/10. Almost most of the patient doesn't complain of any pain. They complain of a little discomfort. That's it. And the blood transfusion, when there is an associated long bone fractures or abdominal injuries, there is increased threshold of blood transfusion. There is a 15%, that means 15 patients, that is 36% patients required blood transfusions in our study. And the mean hospital stay after surgery is usually 7 days. When there is no involvement of major organs or brain injury, the patient get discharged very early after surgery, within a week. Usually we discharge these isolated rib fixation cases on day 5. But when there is an involvement of brain or any abdominal injury, their hospital stay is bit prolonged. And we have 2 mortality in refixation patients. One is a patient who developed pneumonia and went into sepsis on day 18. He also having comorbidities like PKD and hypothyroid, diabetes mellitus, and obesity. And another patient is a coal mine worker which got hit by a coal carrier, a huge coal carrier. He had a multiple long bone injuries along with the chest trauma. He had a bilateral tibia injury, humerus injury. Ultimately, he went into MODS, ARDS, and he was on ECMO for few days, but there was no fruitful result. And the complications we have encountered in our studies. So here you have seen the fracture of the rib plate. So this is very important. When we are fixing the rib fracture, it is very important that the plate should align the rib. So there is a bender available to bend the rib plate. So we have to take the help of the bender, and we have to see the alignment of the rib. Accordingly, we have to bend the the red plate. Otherwise, there will be a stress at that joint area, and it will be more prone to the fractures like this. And there is, in 2 cases, we have seen the displacement of the screw. And we did nothing in this displacement of screw because these 2 patients has never complained any pain or anything. So this screw anyhow it's settled there. So we didn't do anything. They are on under follow up with no major problem. And in 1 case we have experienced loculated pleural effusion and managed, and this condition is managed with VATS. And we are suspecting that due to the more IV fluid administration may cause these kind of situations, so that it is better to restrict in hemodynamically stable patients. So on conclusion, surgical fixation of rib fractures, especially for fractures, is accepted indication, and modified Bemelman criteria is very helpful in choosing the patient to whom to fix. And CT chest is a gold standard and mandatory, and 3D reconstruction is recommended in assessment and planning for surgery. Early surgery within 72 hours is standard, and the benefits are early weaning off from ventilator, shortening ICU and hospital stay, better pain relief, and improved long-term quality of life. Thank you.